it's a wonderful opportunity for us to get Dr. Arun on this platform to talk about one more important topic in GI physiology, that is 24-hour reflux monitoring. So, Dr. Arun, I know from a long time, after he completed his DM from SGPGI, was at the AG for a small time, and then he has moved to Kakinada, and he is working in a center called Arun Gastro and Liver Care. So here you go, Dr. Arun. The podium is yours. Thank you.
Thank you, Dr. Prashanth. Thank you for the introduction. So, is my voice audible? Is it clear?
Perfect.
Yeah. Okay. So what I will do is for next maybe half an hour, for 40 minutes, I would be discussing about a very important aspect of the GI motility workup of GI motility, that is 24 hours reflux monitoring. So, or otherwise what we call as 24 hours pH monitoring. So this is a very important investigation that we usually do to crack some of the difficult cases that we see in our practice, especially those who come with GERD, in suspected case of GERD, in atypical cases where we are not sure what's really happening. So if you look at the types of pH monitoring, there are two types. You do only a simple pH, that is a pH study, or what you do is you can combine impedance with pH, that is called as pH impedance monitoring. So if you do a simple pH, it can be done by different methods. It can be with a wire, it can be wireless capsule, and so on. And also you can also extend it beyond 24 hours. But if you combine impedance with pH, we have only tool that is available is with the wire, and that can be done only for 24 hours. If you want to extend, yes, you can extend it, but you need to break the study and then you need to extend it further. So what's the advantage of adding impedance to pH? So one might ask me, why do you want impedance? Why do you want to add impedance to pH? So there are various advantages of adding impedance to pH. So you can detect the reflux episodes, the nature of reflux episode, whether it is a liquid or a gas, or is it a mixed reflux. And also you can quantify the number of reflux episodes that are happening. Number third is the extent of reflux. Once the reflux happens, till what extent in the esophagus the reflux goes, whether it is confined to the distal esophagus, or does it go up to the mid esophagus or proximal, or sometimes it can also reach the pharynx. So we have special probes that are specially designed to pick up laryngopharyngeal reflux. These pharyngeal probes have impedance channels right up to the proximal esophagus. So these are some kind of advantages that we can have when we combine impedance with pH. So as I told you, gastroesophageal reflux studies can be done with a wire, or it can be wireless. With wire, you can have either pH, or you can combine impedance with pH. Whenever you go for a wireless study, such as the Bravo capsule, you can only measure the pH and not the impedance. But on the other hand, if you're using Bravo capsule, you can even do a 72-hour study. Generally the battery in the capsule will last for 3 days. So you can extend the study up to even 72 hours. So you can get the complete reflux monitoring over a 3-day period. So once you complete the study, what do you see in the final report? So you see basically 3 parameters. That is the acid exposure time, that in short we call AET. So acid exposure time will be available both with the pH and as well as impedance studies. Number two are the number of reflux episodes we get in when we do an impedance study. The number of reflux episodes uh, you cannot get it in a plain pH study because the number of reflex episodes are basically impedance based measurements. Once you are once you have the values of acid exposure time and as well as the number of reflex episodes, the third thing that you see is the reflux symptom association. Whether a particular reflux episode is it associated with a particular symptom or not. Again, I'm repeating the total number of reflux episodes and as well as reflux symptom association would be available only when you combine pH with impedance. So as I told you, there are different types of pH probes. You can have a plain pH probe. You can have a pH impedance probe, that what we call as multi-channel impedance pH probe, MII pH probe. So even in pH impedance probe, you can have two different kinds of catheters. One with only a pH esophageal pH sensor and another catheter with a dual pH sensor, that is a gastric pH sensor and as well as esophageal pH sensor. In addition, as I told you, you can also have pharyngeal probes where the impedance ports are located very close to the pharynx, that is in the proximal esophagus. Commonly in my practice, I generally prefer the 6 impedance channel two pH sensor probe. These two pH sensor probes are nothing but one for the esophagus and other for the gastric pH. So the esophageal position of the esophageal pH sensor is important, not the position of the gastric pH sensor. So esophageal pH sensor should be placed at exactly at 5 centimeters above the lower LES, lower esophageal sphincter, or the G junction. So that is very important. The position of the gastric pH sensor is not that important, but the position of the esophageal pH sensor is important. It has to be strictly placed 5 centimeters above the G junction to measure the reflex going on. So let me tell you some basic principles of impedance. So what is impedance? Why does it help us so much? And how does it make that kind of difference when we combine impedance with pH? So impedance is simply nothing but it is the electrical resistance. So it is the measurement of the electrical resistance between two closely placed electrodes. So there can be two kinds of bolus refluxes that are happening. It can be either a liquid bolus movement or it can be a gas reflux. So liquid water, you all know it's a good conductor of electricity. So whenever a liquid or a water passes from one electrode to another electrode, there is drop in the impedance because it's a good conductor of electricity. There is drop in the impedance value. So drop in impedance value by more than 50% from the baseline is defined as it usually is considered as liquid reflux by the recorder, by the pH recorder. On the other hand, air or gas is a poor conductor of electricity. So whenever air passes or traverses two electrodes, there is increase in impedance. So whenever the impedance rises above 5000 ohms, then it means that gas is passing through, and the pH recorder assumes that it is the gas that is traversing across the esophagus. So this is the basic principle of impedance. So you can all see here, these are the two pictures showing bolus movement. So number one is you need to see whether it is a liquid or a gas that is moving across. And number two, you need to see the direction, whether it is moving in the oral direction or is it moving in the opposite or the aboral direction. In the first picture, you see the pH is dropping. So the pH is dropping. So this is clearly a liquid bolus movement in the esophagus. The second thing is you need to see the direction in which it is moving. So the direction in which it is moving is the aboral direction. So this is a swallow. So when a person swallows, you get this kind of impedance tracing. But if you see the second figure, you see here the impedance is dropping. Again, this is a liquid bolus movement across the esophagus. But in what direction is it moving? It is moving in the oral direction. So the liquid is moving in the retrograde fashion. So this is a classical reflux episode. This is a liquid reflux that is happening in the esophagus. So this is considered to be a reflux episode. So how do you classify the pH recording? So now we have seen some basic principles of impedance, but you need to combine impedance with pH. Only then you will complete the study. So how do you classify the reflux episodes based on the pH? So whenever the pH drops below 4, it is considered to be an acid reflux. But whenever the pH remains above 4, then it is a non-acid reflux. Again, let me give you an example. So if you see here the first picture, the impedance is dropping. So it's a liquid reflux. It is happening in the oral direction. So this is a reflux episode. So you need to classify the reflux episode whether it is an acid reflux or a non-acid reflux. So you need to see the pH tracing. So at the time of reflux episode, when the pH drops below 4, then this episode is considered to be an acid reflux. You see the second picture, again the same thing is happening. Liquid is moving in the oral direction, it's a reflux episode. But the pH drops, but it doesn't drop below 4. So this reflux episode is considered to be a weakly acidic reflux. The last picture, again, there is liquid reflux, but the pH doesn't change, pH doesn't drop. So this is considered to be a alkaline reflux. So in general, the second and third scenarios are considered to be non-acidic reflux episodes. So if you look at the final report of the pH impedance study, you get the number of acid reflux episodes and number of non-acid reflux episodes. So weakly acidic and weakly alkaline or alkaline reflux episodes are considered to be non-acidic reflux episodes, whereas all others which show drop in pH below 4 are considered to be acid reflux episodes. So these are some of the tracings or examples that I would like to show you. So again, I told you that in a swallow, the impedance drops and it happens in an aboral direction. This is a classical example of a swallow. And if you see on the right side, the second picture, what can you appreciate what is happening here? So the impedance is abruptly rising and falling. Again, the impedance is abruptly rising and falling. So you can see three instances where the impedance is abruptly rising and falling. So this is a classical example of a supragastric belch. The pH, esophageal pH doesn't change, but there is abrupt rise of pH and drop. So this is a classical example of supragastric belch. So what happens in supragastric belch? Patient has aerophagia against a closed LES, and he immediately vents out the air from the esophagus. So the LES doesn't open, the air is sucked into the esophagus and immediately it's vented out. So because there is movement of air in the esophagus, the impedance sharply goes up and comes down. This phenomenon happens in a fraction of a second. So you can hardly make out whether it is moving in an oral or an aboral direction. You can only see these kinds of spikes happening when the patient belches. When you have this kind of a picture, especially in a patient with belching, you should classify this as a supragastric belch. Again, let me show you some examples. Here you see the impedance drops, and it drops in oral direction, and the esophageal pH becomes acidic. So this is a classical example of an acid reflux. Again, here reflux episode happens, but the esophageal pH doesn't drop below 4. So this is a non-acidic reflux. Again, here the third picture, you see here what's happening. The esophageal the impedance increases and immediately drops, and it dips down in a oral direction. So this is a gastric belch with an acid reflux. So unlike the supragastric belch, you where you have abrupt rise in impedance and drop in impedance, in gastric belch you will have more of a slow or a gradual phenomenon that is often associated kind of a liquid reflux at the end of the belch. So what are the indications of a 24 hours pH reflux study? So the number one indication, the most common indication is PPA non-responsive GERD, or in cases of refractory GERD. Number two, in evaluation of atypical GERD symptoms, again, it's very important. Parameters or pH studies have not been standardized to diagnose atypical GERD symptoms. You can sometimes uh, uh, use this, as I told you, there are some pharyngeal probes to look at laryngopharyngeal reflux, but even then, nothing has been standardized in any of the guidelines to diagnose atypical GERD. The problem with atypical GERD is like the conditions in which you do, like for example, chronic cough, asthma, suspected LPR. They're all multifactorial, and you generally do not go by the auto analysis given by your pH machine. You should always do manual analysis of the pH impedance tracing whenever you are doing a pH study in a patient with atypical GERD symptoms. So before and after anti-reflux surgery, such as lap fundoplication or endoscopic anti-reflux surgery, yes, 24 hours pH study is a must before you embark on these kind of invasive procedures. And again, in a patient who is having a proven GERD and you need to see the response to treatment on PPI, you can always do this kind of study on acid suppression. So when the patient is already on acid suppression, you can always do these studies and see what's really happening, whether the therapy is working or not. So let us come to the technical aspects of the 24 hours pH study. How do you do, and how do you analyze? So number one is patient preparation. So patient preparation is very simple. Patient should be fasting for 6 to 8 hours. Overnight fasting is sufficient. You call the patient to your lab in a fasting state in the morning. Preferably place the probe in the morning and avoid placing probes in the afternoon or evening, because analysis sometimes becomes very difficult and tricky when you place probes later in the day. Try to place the probe in the morning, fasting maybe at around before 10 a.m. So first thing that you do is you you need to enter the patient details into special in the system, the software that's provided by your the pH, uh, and you need to log in with all the data and save the data into the memory card, and remove the memory card, and then you transfer it to the pH recorder. The first step that is has to be done before you take the probe and place the probe into the patient is electrode calibration. So usually you have two pH solutions that would be provided, pH 4 and pH 7. So using these two pH solutions, you calibrate the catheter, and then you position the catheter into the patient. So placement of the pH probe is very similar to that of a manometric catheter. So you would have seen previous lectures how manometric catheter is placed through the nose. Generally, we prefer placing the placing the pH catheter in a sitting position. So patient is placed. I mean, sits on the couch comfortably, and then you can just apply some lignocaine jelly into the nostril, and then give him some water to drink. And as he drinks water, you can slide your pH catheter uh, uh, across the pharynx. Now, the most important aspect of positioning the catheter is how are you going to locate the LES while placing the pH catheter. So you can do it by two ways. Number one is by manometrically, like when you do an esophageal manometry, you measure the distance of the LES from the nares, and then you anchor the catheter at the same length. Or you can also follow what we call it as a pull technique that I will show you now. Once you place the catheter, that I have already told you that the position of the esophageal pH sensor is very important. That has to be placed 5 centimeters above the LES. So once you place the esophageal pH sensor above the LES, you need to anchor the catheter to the nail, to the nose. So this is very important. You need to use a good quality adhesive plaster to anchor the catheter to the nose. Otherwise, what happens when you do not use a good quality plaster? The gum loosens up, and then the catheter might slip out. So that's very important. So I would personally prefer a 3M adhesive plaster to I mean the to plaster the catheter to the nose. So once you are done, you start the record, and then you send the patient home. You can call him back after 24 hours, and then you do a data transfer. Then you analyze the report. Again, one more important thing that I would like to tell here is, once you before you send the patient to home, or where you admit the patient, instructions are very, very important. So there are some buttons on the recorder. Maybe I don't have a picture of that, but there are some buttons on the recorder, so uh, which would like give some info about the position of the patient, whether patient is in a supine position or patient is in an upright position. Patient has to takes the time of the meal intake, when he starts taking the meal, when he ends meal. And also you also have three symptom buttons on the recorder. So you need to tell the patient to press the respective buttons on the recorder whenever the patient has a particular symptom. So that's only when patient presses the symptom button, only then you can accurately analyze the reflux symptom association. So that's very important. So instructions are important. Whether you place or your technician places the catheter, remember positioning of the esophageal pH sensor is important, number one. Number two, plastering the catheter to the nose is important. Use a good quality adhesive plaster. And number three, before you send the patient, you clearly instruct the patient of the buttons, when to use these buttons, and also instruct the patient to press the symptom buttons whenever the patient experiences a particular symptom. Only then you can accurately get the symptom reflex symptom association score. So let me tell you the pull technique. It's very simple. Like when you use a dual pH catheter, that is an esophageal and gastric pH, you place the pH catheter fully into the stomach. So when you place the catheter into the stomach, the first thing is, when both the sensors are in the stomach, both will be showing you an acidic value. So you can see here in the first picture, pH 1 is the esophageal pH sensor and pH 2 is the gastric pH sensor. So when both these sensors are in the stomach, both will show you an acidic reflex, that is below 4. So at this point, what you do is you slowly pull out the catheter. So when you slowly pull out the catheter, the pH 1 would change from acid to alkaline. So there will be an abrupt change from acid to alkaline value, suggesting that the pH 1 or the esophageal pH sensor is exactly at the LES or the G junction. And from this point, you withdraw the catheter for 5 centimeters. So by doing so, you would place the esophageal pH sensor 5 centimeters above the LA. So this is a very simple pull technique that you can use whenever you don't have a when you don't have a manometric value of an LES, depth of LES. You can always use this simple pull technique to place the pH probe. So how do you define the reflex parameters when you get the final reports? So as I told you, what is esophageal acid exposure or acid exposure time? So it is nothing but the total time esophageal pH drops below 4 divided by the duration of monitoring. So that will give you the acid exposure time in percentage. So with impedance, you can also have what's called as bolus exposure. Bolus exposure is nothing but duration of all the reflex episodes defined by impedance divided by the duration of monitoring. So what do you mean by symptom index and symptom association probability? The symptom index and symptom association probability are nothing but these are the reflex symptom association parameters. So what is symptom index? Symptom index is simply what you do is the number of symptoms divided by the total number of symptoms. So symptoms associated with reflux divided by the total number of symptoms. So whenever the symptom index is more than 50%, you call it as an abnormal or a positive symptom index. Symptom association probability is more of a analytical parameter where we use chi-square to look at the probability of association of a symptom with the reflex episodes. The software here uses a chi-square kind of analysis to see whether a particular symptom is associated with a reflex episode or not. So whenever you have a symptom association probability of more than 95%, then you say it is abnormal. you need to know some of the normative data of the pH measurements. So previously we used to have a cutoff of 4.2% for acid exposure time and 73 reflux episodes, and also we used to measure median bolus clearance time and so on. But in 2018, we got the Lyon's first version of consensus, and in Lyon's consensus, it was clearly defined that acid exposure time is significant when it is more than 6%. Or if the total reflex episodes are more than 80, the total reflex episodes are more than 80, then a patient is diagnosed to have GERD. But recently, this year, we got the second version of Lyon's consensus. So let me tell you some differences between what was in first version versus what's in the second version. In the second version of Lyon's consensus, GERD has been divided into two clusters. The first cluster is unproven GERD, that is, you do not know whether the patient has GERD or not. So this entity is called as an unproven GERD. So you need to diagnose GERD in this patient, in this group of patients. On the other hand, you have a patient with already proven GERD. So let us see what the consensus, what this consensus has put forth, what cutoffs the latest version of Lyon has put forth. So in a case of unproven GERD, so when you do a pH or a pH impedance, acid exposure time is the same, it is 6%. But it has also included wireless capsule in its algorithm. So whenever you do a wireless capsule, you only get the pH measurement, you do not get impedance measurement. So when you do a wireless capsule, the acid exposure time of more than 6% on more than 2 days. So you do the capsule study for a 3-day period. Whenever the exposure time is more than 2 days, that is it crosses 6% on 2 days, then this particular patient is diagnosed to have GERD. But whenever there is borderline acid exposure, that is, if the acid exposure is between 4 to 6%, then it is only a borderline GERD, and you cannot conclusively tell that patient has GERD. So in such a situation, what you do is you take help of other supportive or adjunctive evidence to support the diagnosis of GERD. So this is done by taking the total number of reflux episodes and mean nocturnal baseline impedance into consideration. So whenever you have a borderline acid exposure, that is 4 to 6%, with a high number of reflux episodes of more than 80 per day, then you can call this as a GERD. You can also take help of mean nocturnal baseline impedance. Mean nocturnal baseline impedance is nothing but in the night, what's the luminal impedance in the distal esophagus is measured by the software. So when the impedance is less than 1500 ohms, it means that in the night the patient is having ongoing reflux. So borderline acid exposure with total number of reflux episodes more than 80 and low mean nocturnal baseline impedance, that would suggest the patient is having GERD. But when a patient is having an acid exposure time of less than 4% and with a total number of reflux episodes of only 40 per day, then he clearly doesn't have GERD. So let us see the other group of patients where you have proven GERD, and you need to see whether a therapy is working for this patient or not. So you have put the patient on therapy, maybe a pharmacological therapy, or you have stepped up the acid suppression, or you have done an anti-reflux surgery, and you need to see whether patient is having reflux or not, whether patient has responded to therapy or not. So what you do is you do the pH study on treatment, on acid suppression. So you continue the patient on acid suppression, and then on therapy you do a pH study. So the second version of Lyon consensus has given a separate set of cutoffs for those who undergo pH impedance study on therapy. So let me tell you. So when a patient on therapy, you do a pH, and when you find acid exposure time of more than 4% or reflux rates of more than 80, then it means the patient is continuing to have acid reflux despite patient on therapy. But when you have a borderline situation, for example, acid exposure time 1 to 4%, then you take other adjunctive evidence such as mean nocturnal baseline impedance or total number of reflex episodes to support the diagnosis of GERD, or to suggest that in spite of putting the patient in therapy, the reflux is going on. But on therapy, if the acid exposure is less than 1% and the total number of reflex episodes is less than 40, then it means that your therapy is working, and the patient's symptoms are not related to GERD. So again, this is the comparison between the first version of Lyon consensus and the second version of Lyon consensus. Here I would like to just highlight about the pH study part, because there are other parameters that have been revised in the second version. For example, I would again mention a few. In definitive diagnosis of GERD, they have included grade LA, grade B esophagitis, and they have removed routine esophageal biopsy analysis from the criteria. And when you see the pH, again, they have given separate thresholds or cutoffs for testing on and off anti-secretory or acid suppression therapy. Here they have added even the wireless pH monitoring thresholds as well. And they have given the cutoffs for mean nocturnal baseline impedance. The one that has been removed from first criteria is the post-reflux swallow-induced peristaltic wave index, that is PSPW index. PSPW index has been removed for a reason, because it has to be done manually, and the software has not been designed to give you this index, and sometimes doing it manually is so cumbersome that you might not come up with a accurate result. So summarizing, putting everything together, interpretation and reporting. So when you have a positive reflex by a pH or impedance, going by the Lyon's criteria, so you call the patient as GERD, and you classify whether the patient has acid or a non-acidic GERD. So whenever there is no reflex at all, that is, there is no significant acid exposure, or there is no significant bolus exposure or volume reflex, then you see reflex symptom association parameters. So as I told you, you look at two parameters, symptom index and symptom association probability. If symptom index and symptom association probability are significant, then the patient has esophageal hypersensitivity. But whenever they are not significant, then the patient has functional heartburn. So when you do a pH, you basically come up with four kinds of final diagnosis or interpretation. That is, whether the patient has acidic GERD, whether the patient has non-acidic GERD. The patient has no GERD, then whether it is esophageal hypersensitivity or is it a functional heartburn. So you should be able to, at the end of your pH report, you should be able to comment on one of these four diagnoses. So let me give you some case capsules from my own practice. Very basic, simple. So this is a 40-year-old female, overweight, hypothyroid, presented with heartburn and regurgitation for 2 years. Patient was on PPI. Heartburn improved, but she continued to have troublesome regurgitation and she also had cough. That was not responding to PPI or prokinetics. Endoscopy showed Hill's type 2 G junction, no hiatus hernia. Symptoms persisted in spite of lifestyle modification and weight reduction. A pH study was done. The first thing that you need to see is the acid exposure time. So the acid exposure time is 2.8%. So by strictly going by Lyon's consensus, the patient doesn't have GERD, but on impedance, she had 165 reflex episodes. So this was quite significant. So this patient basically had non-acidic volume reflux. So this patient was referred to a anti-reflux surgery. Again, coming to the second case, a 35-year-old gentleman presented with heartburn, chest pain that increased postprandially, lasted for 3 years. He had partial relief on PPIs and prokinetics. Endoscopy showed hiatus hernia, and patient was being planned for a lap fundoplication just because he had hiatus hernia and he had GERD symptoms. But did when we did a pH study, the acid exposure time was only borderline elevated. That was only just above 4%. The reflex episodes were also not much elevated. It was only 55. And if you see here, there were quite significant number of reflux symptoms recorded during the study. So 55 episodes of belching, 11 episodes of chest pain, and 20 episodes of heartburn. When you look at the reflex symptom association parameters, the symptom index was less than 50% for both acid and non-acid reflux episodes. Again, symptom association probability was less than 95% for both acid and non-acid reflux episodes. So the reflux symptom association was poor, and this patient had functional heartburn and chest pain, and patient was then put on patient was counseled, reassured, and patient was put on neuromodulators, and the surgery was different. So this how doing a good pH-impedance study will plan your management, counseling, and can diagnose some. You can get this kind of interesting diagnosis, and you can avoid some invasive procedures such as anti-reflux surgeries. And these surgeries should be done only when it's absolutely indicated, having solid evidence on these kind of reflex monitoring studies. So this is my last slide summarizing. The patient has GERD symptoms, whether typical or atypical. Once you're done with basic workup such as upper GI, manometric, and so on, you generally classify them into PPI responsive, PPI non-responsive. When a patient is PPI responsive, you titrate the PPI, then you reduce the PPI, put the patient on PPIs on demand. But whenever PPI, when the patient becomes PPI dependent, or whenever the patient is reluctant to take PPI, wants a definite anti-reflux surgery, then you do a pH impedance study. But on the other hand, if a patient is PPI non-responsive, then definitely this is an indication for 24-hour pH-impedance study always. Remember, if in a case of a non-responsive GERD or refractory GERD, pH impedance is always preferred over a simple pH study. So in a pH study, in a pH impedance study, again you classify them whether the patient has a true reflux or a patient has esophageal hypersensitivity or a functional heartburn, because the management totally differs between these two entities. Thank you very much. So if you have any doubts, I would take up.
Uh, Thank you, Dr. Arun. It was very nice, slowly and very effectively and clearly discussed the topic. Thank you. It's a pleasure to have you here. So I'll slowly go ahead with the question and answers session. So few of the questions that have been asked are there in the chat box. Let me just read them out for you. Uh, yeah, Dr. Sriram has asked, upper border of lower esophageal sphincter, how do we locate when the LES is going up and down like a wave? He also has asked other questions on PPI. How do we evaluate? Is it better to do off PPI? This was the initial stage of the session he has asked. Then symptom index, symptom association probability. How do we see it if we have multiple symptoms with values like say 5%, 70%? Do we put it under esophageal hypersensitivity or functional? Okay, so most of it has been discussed, but maybe you can just briefly take it up quickly.
So the issue of the LES moving up and down usually happens like that can be like when you do an esophageal manometry, you can see these LES moving, I mean, up and down. That usually happens when the patient takes very deep inhalation and exhalation. So whenever the patient is breathing quietly, usually these kind of wavy patterns usually can be avoided. So you should always ask the patient to take normal breathing. So whenever the patient takes a deep inhalation, then you all know the LES changes. I mean, the kind of wavy pattern when you do a manometry. So if you look at the Chicago classification, the protocol, that what they say is you take three deep breaths, then you see the pressure inversion point, and then you take normal, I mean, baseline recording with normal breathing. So always do a recording when patient breathes normally. By doing so, these kind of variations can be avoided. I would rather suggest a manometrically measured LES position combined with the pull technique. So both, if you combine both, then the error of you placing the catheter too high or too low can be avoided. See, I mean, it's very difficult to accurately place it 5 centimeters above the LES. There can be an error of maybe 1 centimeter. So that's how I do. Like, you need to combine both manometrically measured LES position, depth of the LES with pull technique, both combined together. I think you can minimize the error. And the third question that was asked about the reflux symptom association. So you need to, so patient might be having multiple symptoms, but you need to first prioritize the symptom that you're going to, I mean, see, report or what, because a patient might be having belching, patient might be having heartburn, chest pain, regurgitation, so on, multiple symptoms. But first priority should be given to typical GERD symptoms. Heartburn, chest pain, regurgitation. These are the typical GERD symptoms. Belch is not a GERD symptom. So whenever you look at reflux symptom association, the first priority should be given to typical GERD symptoms. For example, if patient has heartburn, you give importance to heartburn. If patient has chest pain, the chief complaint, chest pain, you give importance to chest pain. You forget about other things. The patient might be having belching. patient might be having a positive symptom association for a belch, but a negative symptom association for a heartburn. So in that case, you always take heartburn into consideration and not the atypical symptoms. So that maybe, that would be the answer for the question.
Okay. Dr. Swaraj has asked, how many hour data is minimum required to get results? Because sometimes the battery gets off earlier or the screen's gone, probe is out, some mishandling. So this is sometimes so we find out these kind of situations. So minimum time to get a diagnosis.
Yeah, that's a good question. That is why I had told you, like, place the probe as early as possible in the morning fasting. Do not place the probe in the afternoon or evening. But in case if the probe dislocates or the machine stops working, I think at least 16 to 20 hours of monitoring is a must, because anything less than 16 hours will not give you a proper measurement. And you should also remember, like, the pH monitoring will not be complete without the nocturnal period analysis. So nocturnal period analysis is very, very important. So not without nocturnal period analysis, your pH study will not be complete. So I have encountered some of these issues in my practice. As I told you again in my presentation, you need to use good adhesive plasters. If you do not use adhesive plasters, what will happen is the gum loosens up and then the probe, or the catheter, slips out. So you might get some erroneous values and so on. And when you don't use proper batteries, like for example, you use a normal battery, don't use a when you don't use a Duracell, you use a normal battery can get exhausted, your study gets. But I feel minimum of 16 hours and nocturnal period, maybe at least some part of nocturnal period being included in the study is always good. But again, there are no guidelines like what should be the minimum. 24 hours is always ideal.
Any role of demister score still, or
So demister is only for pH, not for pH impedance. Demister score has, whenever you do a combined pH impedance, demister doesn't hold any value. But when you do a plain pH study, then demister, usually the demister goes in line with your acid exposure time. When the acid exposure time is more, demister score increases. So they go hand in hand parallelly. But when you combine impedance, demister doesn't have any value because demister is only for acid reflux.
sir, sometimes we get MNBI as no value at all. This is commonly seen in a significant number of patients. Like MNBI, I don't know what happens in night. Probably the patient doesn't press the supine and to recumbent, or something happens that MNBI is just not there. What do we do then? Is it of any role? Only in unequivocal cases we get to see it. So, any ways to avoid it?
So MNBA value not appearing in the report, there are two main reasons. Number one is the software has not picked up, or like there are some technical issues with the probe or something. I don't want to discuss all these things. If you use the probe like more than a couple of times, sometimes what will happen is you don't get the MNBA value, because even you don't get the impedance. So to get a proper MNBA value, you need to have all your impedance ports properly working. Though it's the distal impedance channel that picks up the MNBA, the impedance channel should be like properly. You don't calibrate impedance, you calibrate only the pH, remember. So when you repeatedly use the catheter, what will happen is the impedance, accuracy of impedance detection goes down. That is one reason. The other reason is when the movement of the probe is too much across the, like for example, again I told you, if you have not properly positioned the probe and you the probe moves a lot across the G junction. Sometimes like the software might not be able to calculate MNBA. So most of the situations that these are all mainly related to the technical issues. It's not that if you don't get MNBA, it doesn't mean that the patient doesn't have reflux or has a reflux. Most of the time, it is technical issues that you don't get a proper MNBA value. Again, I am not sure. We should not go solely with MNBI. It's just a supportive evidence, supportive criteria. So, for example, if you have a very high count of reflex episodes and you don't get an MNBI value, that doesn't make any difference. So, mostly not getting an MNBI value is a technical issue rather than a problem with the patient.
Dr. Mohit has asked how to identify retrograde and anterograde movement in graph.
So I have showed you in my presentation and some of the graph that I have taken from my patients actually. I've taken some snapshots and showed you. Usually what the in the software, like when you like play around in the software, you can actually apply these kind of brackets to the reflex episodes. So when you switch on the when you switch on the reflex episode, or when you want to highlight the reflex episode, the software will itself will like bracket apply these brackets to the reflex episodes, and it will show you the direction where how it goes. I have showed you in my presentation. I mean, that's very simple. It's not that difficult. But the only thing, it's time taking process. You need to manually zoom in the analysis for maybe 1 minute or 2 minute interval, and then you need to see each and everything. And also, you can also the software gives you some color codes, maybe for an antigrade reflex or retrograde reflex. The software gives you some color codes to tell you like in which direction it moves. So it's very similar when you do a impedance manometry. The impedance is usually given by the pink color. So if you had seen the impedance manometry tracing, you see the pink color of impedance. This same representation you get with these kind of with the Sandal software that we use. I mean, that's not difficult. I mean, you just need to play around with the software, and you can easily identify the direction of the bolus movements.
Okay. Dr. Ashok Mohit has asked, what's the lower age limit where we can do a 24-hour pH impedance? Lower age limit.
So there are some neonatal probes as well. You can do pH measurements for even neonates as well. So there is no age limit. You can do pH for any age, even in newborns you can do. You have different probes, especially as I told you, for infants you have different probes. They're very small probes. But there is no age limit. It all depends on the age and what kind of probe. I think Ready Stock has pediatric probes as well. So when you're suspecting this kind of GRD, especially in infants, neonates, definitely you can use those probes. And they're very short probes, so there is no age limit. Any age you can do.
Okay. Thank you, Dr. Arun. We have to leave you by 6 p.m. for another session, so we don't want to take too much of your time. There are still multiple questions which will come on. Maybe we'll take up some other time when
Maybe you can mail me so that
absolutely, that can
yeah.
be done by me and maybe discuss before the next session. So thank you very much, and I would just want to tell all the audience that the next session will be by Professor Uday Ghoshal sir on evolution of GA physiology on 17th of November at 7 p.m. So please stay tuned for the program then. For live would be much better to have you all with a lot of questions. Maybe I'll stretch the session a little longer that time. Let's see. Thank you one and all for attending this session on a Sunday evening. It's a lot. It gives a great pleasure to have all the young gastros around and actually try to motivate in a subject which is given less importance to. Of late, a lot of interest are seen in GA physiology. Very nice to see this. And Dr. Arun, you have done a wonderful job in discussing this complicated topic. You have demystified it to some extent, we can say. Maybe AI will take up a little more of the manual work and give us little more reduce the time if some of us are interested in doing the manual evaluation of the entire pH study. So thank you, Dr. Arun. It was wonderful.
Thank you, Dr. Prashanth. Thank you very much.